Sure. So this one, like, kind of simple. It's like, okay, which vaccine? Um, and I'm like, okay, I wouldn't think influenza because it's active and they're immunosuppressed, but that's not true. So, and the only reason I was thinking meningococcals because I think something was going on with the spleen with this patient. Is that true?
Well, yeah, I mean, I guess my thing is, um, okay, so let's work this together. So what
Okay.
kind of vaccine do you want to give somebody who is immunosuppressed?
You want to give them a killed inactivated vaccine.
Yeah, killed and activated.
Hmm.
So MMR is live, pneumococcal. I mean, she
I
already
mean, she's over 65, but it already said that she received it like
Yeah,
last
she
year. So
already
I'm like, okay.
received it, so that's not good. And then
Hmm.
meningococcal, right, is usually, for people um that are around, around people that can have,
Right.
next meningitis. So probably not. And then varicella, right?
That one's
Varic
live.
that one's live, so you don't want to give that.
Mhm.
So your best bet here is actually influenza because everyone needs
Okay.
influenza annually, and it's a
Right.
death vaccine, right? Unless you're getting the one sprayed in your nose, which is live.
Okay. That's what sometimes they do that when they don't say it's the inactivated one. That's what I thought. So I'm like, oh,
Yeah,
I don't
so
want to give that one.
flu is pretty much always inactive. But yeah, I mean,
Okay.
that's something that we have to always get, even as providers, right? So
Okay. Okay. This one I did not see it as anaphylaxis, because it was 6 hours. So I'm like, okay, it's not anaphylaxis. It was more of like a Herx reaction or something. So they test that a lot. Um, because anaphylaxis, I'm thinking is very fast, and then she didn't have a temp. Blood pressure was down a little bit, and they're like, okay, she has some urticaria. Um, that's what I was thinking with this.
okay, so let's start with this, right? So you have 6 hours, right? I'm gonna follow with you to see,
Okay.
so 6 hours, right?
Hmm.
Beginning, a medication for cellulitis, right? So antibiotics for
Hmm.
cellulitis. And then all of a sudden, right, 37-year-old woman comes to the ER due to a 3-hour history of pruritic rash, dyspnea, and mild cough. So just from that sentence, what should be like highly suspected?
Um, 3 hour Pritic rash, dyspnea, mild cough, and right after taking the antibiotics, something's going. So she's reacting somehow, right? It's either
Yeah,
going to
yeah.
be
So in your mind, you might not jump to anaphylaxis, but you got to be thinking what? You got to be thinking some kind of allergic reaction to the
yes.
antibiotic. Does it make sense?
Hmm. Yes,
Has to
completely.
be, right? There's no other,
Hmm.
it's a cause and effect, right? And then,
Yep.
she has a childhood of history, but no medical medicine allergies. Um
Okay.
the rest is, no, not here nor there. But then it says pulse is tachycardic, she's
Right.
tachypnic, so she's, breathing a lot faster, and
Hmm.
she's hypotensive, right? And then her O2 is 92%. She has, wheels everywhere, right? And
Hmm.
then she's itchy, right? She's wheezing, right? So all of this is showing you that she has an allergic reaction to
Okay.
a drug, right? So
Okay.
even if it's, if it's an allergic reaction, she's having trouble breathing, that's in the realm of anaphylaxis. You get what I'm saying? It's not full blown
Yes.
anaphylaxis, but it's in the realm of anaphylaxis. So the best way to go with this is you got to give epi.
Just as a pressor, right? So like, okay. But I'm thinking, is there a thing with blood pressure that I should have seen or no? Because I'm like, okay,
Well,
86 over 64, it's not super low, or that's not
yeah,
really why.
it is hypotensive, but
Okay.
epinephrine is going to bump that up too, right? But
Okay.
epi is going to not only bump that up, but also allow you to breathe because the swelling will instantly go down, right?
Okay.
You kind of fight off your, allergic reaction to your drug that you took, right? And
Okay.
prednisone, right? If you talk about prednisone itself, it's a steroid which helps with inflammation, but it takes way too long. So that's not
Okay.
really help in this situation here.
Okay. So maybe later you'd give the
Yeah,
prednisone, but
later
not
you
right now.
can, but
Okay.
definitely for sure, you know, um, epinephrine here is going to be your best. Any kind of respiratory symptoms with allergies, you want to give epinephrine. Doesn't matter at what extreme. You get
Okay.
what I'm saying? So
Okay.
wheezing, trouble breathing, right? Tachypnea, right? Epinephrine.
First thing. Okay. This one I didn't see because I really didn't know what to pick for this one because none of them jumped out at me. And I'm like, okay, we had 32-year-old African American man, iron deficient anemia. He does take his ferrous sulfate, and I'm like, okay, no blood, no bloody vomiting, no blood in the stool. Rest of the stuff, okay, no pallor, no icterus. I'm like, okay, these labs are super similar. There's really not. I don't. My highlighting's not that. I don't know. It's like
It
weird.
doesn't
It's not.
save usually when you review it, so it's not
Oh,
you.
okay. So yeah, I'm
Yeah.
like, I don't know why it like looks funny. I'm like, I don't think I would have highlighted like this. Anyway, but I really wasn't sure. After reading the explanation, I'm like, okay, thalassemia. I should have seen that a little bit better because there wasn't any change in these labs, and I think he
And
just
also
came
a
for
key
follow
thing
up.
too. Yeah, a key thing I want to let you know is so for instance, the iron, right, went from 60 to
Hmm.
75. So that means he does take his regimen, right?
Okay,
And his transferrin levels are normal, right, for the most part,
right.
right? So you know
Hmm.
it's not really an iron issue. So you got to be thinking in your differential, oh, what else can cause microcytic anemia? But also on top of that, it says they have target cells,
Okay,
right? Target
that was the
cells are
key thing.
pretty, yeah, that's a pretty big thing for thalassemias. But when you're thinking microcytic anemia, you're thinking iron deficiency, you're thinking your,
Anemia
alpha
of chronic
beta
disease, I was
thalassemias.
thinking of as
Yep.
well.
Hmm.
Okay, so it's really that was the key thing that I just missed, I guess, was the
Yeah, and
target
then
cells.
pure red blood cell aplasia. I'm pretty sure what ends up happening is your bone marrow, your reticulocyte is going to be really low too.
Okay,
If I
let me
believe,
see.
but they don't give
It
that
might say,
here. But
yeah, precursors. Yeah, complete destruction.
yeah, so go up
Precursors.
here. Did they give you a reticulocyte count anywhere or no?
No, I don't think so.
Oh, okay, yeah, no, no,
No, I don't think so.
yeah, no.
Okay. So that one I might have just not gotten because I didn't, or I might have just forgot the target cell idea. I mean, it makes sense now that I look over it. Okay. This one similar, similar, or I guess maybe not similar presentation. So sickle cell disease, lower back pain. I'm like, okay, we need to treat the pain for this. It's like a sickle crisis. And I was thinking, okay, he also has something going on with like urea nitrogen was elevated, creatinine was elevated. So I'm like, okay, nothing that affects kidney. Because that would be like the first. I'm just thinking in like pain order. I'm like, okay, that would be first. Um, and then I was wrong because they're like, oh no, you're going to want to give intravenous, not oral, because I guess because of the nausea, and he has decreased intake of solids. So I'm like, okay, this explanation makes sense. It was one of those ones where I'm picking, like, I'm like, okay, wouldn't we want to do oral oxy first? But apparently that's not correct.
Well, yeah, I mean, I would say here is, we always talk about it, but in internal medicine and things like that, or even in peds, that sickle cell crisis is extraordinarily painful. So you want to give, the most fast acting aborting pain medication here, right? So
Okay.
oral oxy, anything that's oral is going to take some time for you to feel. You know what I'm trying to say? Like
Yes.
to
Hmm.
digest, get in your bloodstream, etc. Right? But IV is directly into the venous system, and so it acts almost immediately. So I mean,
Okay.
I immediately is probably not the right thing. I can't remember
10
2
minutes.
to 5 minutes or something like that.
Oh, that fast?
Right.
Okay.
So it's pretty fast, right? And so that's going to give the pain relief the best here. And so definitely morphine's going to be your best answer here. Rapid acting.
Okay. Okay. Um, this one I knew that it was I was looking for high anion gap, so I crossed out those, and then I'm like, okay. I always thought that with the tinnitus, I knew it was she had the tinnitus and was taking aspirin. So I'm like, okay, I know it's salicylate. I'm not sure if I'm saying that right. Toxicity.
Mm-hmm, mm-hmm.
Um, and then I'm like, okay, I thought that that's one of those where it's a respiratory alkalosis followed by then a compensatory Or is it, do I have it flipped? It's like respiratory acidosis followed by, I couldn't remember which verb.
So it's like a metabolic acidosis because I always remember it's like
Okay.
salicylic acid. So it's a
Okay.
metabolic acid, but you get,
Acidosis.
yeah. So yeah, metabolic acidosis with respiratory alkalosis.
Respiratory
Okay.
alkalosis. Okay.
So if you think about it, right, they counteract each other. So it's
Hmm.
the reason why they're like testing this is the pH is very, very close to normal. That's the reason why they're
Oh,
testing this.
okay. That's
Yeah.
because that's why I went with acidosis, and I'm like, okay, because I just went, I know it's high anion gap, so I just did that really fast. And then because it's closer, because I didn't know which one to pick after that. I'm like, I don't know. I'm like, all these look
Yeah,
similar.
yeah. Because you have, both things happening at the same time, the pH will be close to normal, like around 7.4.
Okay.
So,
And I'm thinking it because like at first you're gonna blow off all that CO2 because you're like panicking. I mean, the patient's panicking, and then over like
so
12 to
the
24 hours, that bicarb's gonna compensate, right?
well, no, 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 that's not how that works, right? That's what I'm trying to say. So it's very specific. So it's a metabolic acidosis because the actual like aspirin is salicylic acid. So it's a
Oh,
metabolic
okay.
acid, right? So that's going to drive the, HCO3 down, but it also causes respiratory yeah, yeah, exactly. Actually, you're right. Respiratory drive to blow off a bunch of CO2. So they
Okay.
both act at the same exact time. And so what ends
Okay.
up happening is you're super metabolic acidosis, but you don't have a lot of CO2 in your body. So then it makes the pH like normal.
Okay. So
You get
it's
what I'm saying? Yeah.
yeah, so I should just think when I see this something like this, it's gonna be normal with the high anion gap, and then that kind of narrows the answer. You can't pick it.
Yeah,
Like
it's
if they
like the
had,
only, yeah,
yeah, that's the only one that's really available. Okay.
yeah.
This one was weird. I'm like, okay, I'm thinking usually for plaque psoriasis, I'm thinking of the extensors, and they threw it all over like the patient's back here. So I was like, okay, it has to be maybe it's. I'm like, maybe that's like the something else. So that's why I didn't think it was psoriasis. But
Let's
I mean, it
see.
looks like psoriasis, but
Yeah, I would say it looks like psoriasis. And it also, they have it on the extensors,
yeah, like
on
right
his
here,
elbow.
right? Maybe
Yeah, his
or okay,
elbows and whatnot. And so yeah, this is gonna be the best. And that silvery scale is, and
yeah,
you can see it some on his scalp too. And remember,
okay,
psoriasis is can be systemic, like all over. So
okay. So it's just a simple like okay visual question there. Um, this one was a pseudo gout question.
hmm.
Um, did they say with the calcium? Did they say it actually? 6-7-year-old man, 3-day
Chondro,
moderate pain.
yeah, chondrocalcinosis. Chondrocalcinosis. So there's calcium, right, in the
Right.
cartilages.
I was thinking is like a degenerative osteoarthritis, which is
Hmm.
why I chose that, not the crystals.
Well, let's see what else they say. Not sustain any recent trauma,
Hmm.
hypertension, uh, erythema, moderate line,
No fever,
no fever.
but then they do say here, okay, right knee is erythematous, warm, moderate effusion. I'm like, okay, palpitation over the joint line. I'm like, something's going on, but no fever. Um,
This, I would say that this is a good 50-50 here. I would say this
okay,
is a tough like one. I'd say the only thing I guess you can differentiate is that, you know, maybe if they give you a little bit more of a history of it hurts more when he walks, like at the end of the day, right? The more you use it, the worse it gets.
that's
Uh,
for osteoarthritis, right? The more you use it, the worse it gets.
yeah,
Like, okay,
osteoarthritis. Yeah.
okay,
And his BMI is not horrible, horrible, right? He's not
right.
obese,
It's
he's
not above
overweight.
30. Okay.
Yeah. So, yeah, I mean, I like this 50-50 actually. This is not bad.
Okay. So not the worst choice here. Okay. I
Nope,
like
not the
narrowed it
worst choice.
down. But then
Yep.
you're right. Like if they usually do say like worse with motion or like worse with activity, and then um okay, that makes sense. This one I thought was weird. I should have just maybe seen I was just reviewing this before. So it's just a soft tissue injury and So 57-year-old man, 1 week history of painful mass after lifting several heavy boxes. He had this chronic shoulder pain, okay, smoked cigarettes, okay. But then I'm like, okay, 2x3, tender mobile mass palpated on the anterior aspect of the right upper extremity. I guess I didn't really focus on this pain with forward flexion, right shoulder. That makes sense now. Active flexion is limited by pain. Maybe there's because there's all these things with pain. And then I'm like,
Well, I
okay,
mean,
vague inter
yeah.
soft tissue shock.
Well, I mean, I want you to, I think, I want you to focus on something key here, okay? The
Okay.
very first sentence is very, very key, okay? 57-year-old man comes to the physician because of 1 week history of painful mass on the right arm after he lifted heavy several boxes. So if you isolate that, that's a chief complaint. So this is an
Okay.
acute issue that happened after a specific event. So you got to pick a diagnosis that is an acute and can happen when he's lifting something heavy,
Oh, okay.
right?
Yeah,
So that
lipomas
can't,
usually are very like long, chronic. They tend to be on the back. I was
yeah,
thinking about it. I'm like, they tend
yeah,
to be like next to structures usually.
yeah. And
Okay.
lipoma, if you think about it, they're usually not tender, they're not painful, right?
Right.
It's collections
They're
of
not.
fat, right? And an
Hmm.
abscess, right, would have a fever. He doesn't really have a
Yep,
fever.
that's what I was thinking. I was like,
You
can't
know,
be abscess. He has no fever.
AV malformation
Okay.
doesn't make sense here, right? And then malignant fibrohistiocytoma is like kind
I
of
don't know what
a
that is.
degenerative soft tissue mass.
Okay.
That's kind of like cancer. So it's not really a acute issue. You know what I mean? So the
Okay.
only one that really makes sense here is going to be C.
Okay. Because we were down because it's so acute. It was either abscess or biceps tendon rupture. And because he did lift heavy boxes, it makes sense. I've known someone who like tore their bicep. It looks really funny. I've seen it.
Yeah.
Um, okay. This one was EKG one. I thought I was doing better with this. Let's see. 72-year-old, here, zoom out on it. 72-year-old woman, admitted to the hospital, 3 week history, progressive shortness of breath, 20-year hypertension, um, smoking history, significant. Okay. S3. I didn't think it was diastolic dysfunction because she did have a good ejection fraction.
Mm-hmm,
Um,
mm-hmm.
and I'm like, okay, that's why I kind of got rid of these as well. I'm like, okay, it can't be systolic or diastolic dysfunction, but I don't know what I missed here. Let's see.
Let's see. Okay, so first you got to ask yourself, does like let's go back to it, right? So
Okay.
older woman, right? 3 week
Mm-hmm.
history, shortness of breath with exertion. Okay. 20-year history of hypertension. So you know that she has high blood pressure for a long, long time. She also smokes, which doesn't help. And then, right, you want to go to um vitals, which show high blood pressure, right? She doesn't
Mm-hmm.
have jugular venous distension or peripheral edema, but she
Okay.
has crackles over the lower lung fields bilaterally, right? So that's pretty
Okay.
key. So then you got to be asking, okay, so why does she have crackles? So most common causes of,
Just fluid overload, are you thinking with that?
yeah, like I mean, a
Okay.
backup of pressure from the heart to the lungs causing pulmonary edema, right? So you know it's a
Okay.
cardiac question automatically because they already give you an EKG too, so you can use
Right.
that. So then you know probably some form of heart failure, left-sided heart failure based on symptoms. Ejection
Okay.
fraction is relatively normal in the normal range. So then you're like, okay, so if it was below, I can't, below 55,
55. Yeah, I think it's
yeah, if it's
55 to 60 is normal or 65
yeah.
normal.
So
Okay.
if it's below 55, then you'd be like, oh, that's systolic heart dysfunction, right? But since it's
Correct.
normal, then it's this diastolic dysfunction. But high
Okay.
output heart failure is something completely different. That's usually with people with like AV malformations where, the venous system there's some vessels that bypass the venous system back into the arterial side, or no, reverse actually, arterial bypassing to the venous, causing more preload faster back to the heart. That will cause
Okay.
high output heart failure, but there's no, risk factors for AV malformations and things like that, so.
Okay. Okay. I thought it was high up based on the ejection fraction, but that's not the way to think about this.
Yeah. Symptoms first, it's heart failure. Then you got to figure out what kind of heart failure. And because they give you ejection fraction, which is normal, that's going to be diastolic. And a lot of times, too, high blood pressure or hypertension will cause concentric, right? Concentric hypertrophy of the left ventricle, causing
Pushing
kind
it
of
out, right?
that.
Like pushing
Well,
or
it
no,
would cause a
no.
beefier heart. Do you get what I'm saying? You get a beefier
Yes.
heart because you have to push against high blood pressure. And with the beefier heart, you have diastolic dysfunction usually.
Gotcha, because it can't fill as readily,
Exactly.
right?
You're
Okay.
not feeling as much.
Okay. All right. This one, it even goes back to like, okay, um if it's a diastolic murmur, I'm like, okay, there can only, I'm usually thinking with diastolic murmurs, mitral stenosis, is on there, and I'm like, okay, I knew it had to do something mitral. I'm like, okay, insufficiency, because the murmur was like 1 out of 6. Now I don't know, but I remember doing something where they're like, oh, if it's less than 2 out of 6, you shouldn't consider it. I don't know how true that is, but that
So
was my
so
thought
that's
process
if
with
it's
that.
less than 2 out of 6 and it's systolic, then it's likely an innocent murmur. It's not really bad. But anything diastolic is not good.
Okay. Okay.
That's usually what they mention. But yeah, so it's at the apex, so it's at the mitral
Yes.
valve. Then you got to
Hmm.
figure out, okay, which mitral valve issue is a diastolic murmur, and that's going to be mitral stenosis. So
Yes.
if it's systolic murmur at the apex, that's mitral
And
insufficiency
I
or
think MR, right? And which I guess MR is mitral insufficiency. I
yeah,
didn't know that.
that's MR.
Okay,
Yeah.
I just thought that was like something else. I'm like, oh, I'm like it's some sort of mitral issue. That's why I picked that.
Yeah,
Um,
regurgitation and insufficiency are the same thing.
okay, that's good to know. Okay. Otherwise, that's not too bad. I mean, I don't know what the blood tinged sputum has to do with anything.
That's just
Um,
yeah, that's just like the backup, like I was telling you about, right? So the
okay,
backup of pressure, you can get some of that fluid into your lungs, and some of it can be blood tinged.
all
So
right. Um, this one, let's see. They had a venous duplex ultrasound, showed left lower extremity occlusions. I'm like, okay, this person definitely is at risk for DVT. And I'm like, but if they have, my thinking was if they have the occlusion already seen and they're just put on prophylactic low molecular weight heparin for an operation, aren't we going to initiate TPA? And I guess not. And I guess it should be more heparin, like continuous heparin therapy.
yeah, so let's talk about this is a good
Okay.
question here.
Okay.
So all of these can help with clots in a sense,
Okay.
right? But TPA, when is TPA used? Do you know by any chance?
I thought TPA was just really used for like stroke, right? Or you see something on the CT and then it's decision, okay, we're gonna use TPA or not. Or if there's sometimes it's used also with the PEs. So it's like, okay, PE or
Yeah,
something on CT is seen on
yeah,
the
yeah,
head.
yeah. So TPA is usually used for stroke. I would say mainly. It's not really first line for almost anything. And the way
Okay.
I think I mean, for stroke, it's even a certain protocol. I think it's under 90 minutes or under 4 hours. I can't remember what it is, but it's a very tight window, which you can even use.
I think it's 90 minutes,
Okay, it could be 90
if I
minutes. And the
remember.
reason
Yeah.
why is after that, right? There's an increased risk maybe for hemorrhage or something like that, right? But anyways, so practically what I'm trying to tell you is TPA is not used many times for first line. Usually you want to use anti-coag, like heparin drip as a first line for DVTs and clots and things. Even for
Okay.
PEs, you'll use heparin. And I guess I mean, I'm reading it, it says if heparin fails, then I guess you can try, you know, TPA to see if it works. But I mean, I've never seen it in clinical practice, but I think it just works too well and you just bleed. You get what I'm saying?
Okay.
Because you're
Okay.
trying to dissolve the clot, but you're not trying to, um, you're not trying to bleed. You get what I'm saying? You're trying to just dissolve
Okay.
that clot, right? So definitely for sure, heparin is always going to be a good one.
So just continue, because then I was also thinking of this question. All right, I'm like, okay, they already started prophylactic heparin, but with this, they're just saying to continue it. as
Yeah,
opposed to stop
you're
it?
gonna no, you're gonna want like a heparin drip or heparin therapy. That's more aggressive than just a prophylactic heparin based dose. You get
Okay.
what I'm saying? So a
Okay.
a therapeutic heparin dose is a lot higher than a prophylactic. You know what I mean?
Okay. And then
So
that's
it's
like the
different.
3 times a day where it's pushed, or
I can't
you
remember.
might just.
Sometimes they do IV drips,
Okay.
sometimes they give it, multiple times, but definitely the dose is like significantly more. So
Okay. Um, this was a like a lung cancer question. Um, I thought it was the impaired mucus clearance. I guess that's more of like um like a chronic issue as opposed to something like obstructive. So 57-year-old man, he had the clear sputum, progressive shortness of breath. He has diagnosis of non-small cell carcinoma of the lungs. I'm like, okay, received chemotherapy. The crackles are heard at the right lung base. I'm like, all right. He does seems to have like an active infection. I'm thinking pneumonia.
oh yeah, yeah.
And then I'm like,
I
okay, guess
mean,
it's not the mucus clearance because that's more of the
yeah. So
chronic
so
thing.
so what I'm seeing kind of with this test is I think you're focusing too much in the weeds and not looking at
Okay.
the big picture. I think that's what's going on when you took this test because
Okay.
if you see someone with a history, I want you to go off that, right? Because in the first sentence, going back to that first sentence, right? They tell you, he has shortness of breath, it's an acute issue, but they also say, or I guess the second sentence. The second sentence says he has lung cancer, that he's
Hmm.
undergoing treatment. And then at the
Hmm.
very end, it says the chest x-ray shows that there's a mass, right? Perihilar mass, which is likely his lung cancer that's still being treated for. And then now he
Hmm.
has an infiltrate, right? Meaning a lung pneumonia on the same side the mass is. So you got to pick an answer that addresses, the cause
Gotcha.
and effect, right? Which is likely, oh yeah, he has a mass, which then that mass probably blocks some of the bronchi or alveoli. And if air doesn't flow, air will eventually become infected, right? And you'll get pneumonia. So that's going to be
Okay.
your best answer here.
Okay. And it makes more sense now. It's like, okay, so maybe as I move forward here, if I do some more stuff tonight later, it's like bigger picture, focus more on that history, like chief, like we've done before. Like, what is the root of the question asking? Chief complaint, history, that should orient me better than I think I seem to be like picking, like you said, picking apart these little details and picking an answer based on that, as
Yeah,
opposed to
I'm trying to get
okay,
you to think of big picture. Like
okay,
like just kind of if you saw this patient in real life, right? You're not going to be like, oh, he probably has pneumonia because of impaired mucoclearance, right? You're going to be like,
right.
probably something with his cancer or even his chemo and radiation would be a good one too, right? It's like,
Yeah, I was thinking that, but it was like a while ago, and I'm like, okay, it doesn't make it
sure,
like he
exactly,
finished it
right?
2 months ago. So I'm like, all right, well, I don't think it's that. If he just finished it last week, then maybe I would consider that.
Sure. So I'm thinking, if I were to look at this, right? Look at kind of your answer choices that you crossed out and left. I would be okay if you had A, C, and D there. You understand what I'm saying?
Okay, I see what
Because
you're
that
saying.
deals with his whole picture, right? But B and
Hmm.
E are kind of, they're adjunct, right? It's like, oh, it could be, but it should be less likely on your differential.
Yeah, they said nothing about hoarseness, nothing about lymph nodes. So I'm like, it can't be some sort of recurrent laryngeal nerve compression issue there.
Yeah.
So, okay, that makes more sense. I'm like sort of inverting the questions.
Yeah. Yeah.
Okay. This one, they always tend to ask about this asthma choices and like choice of, and I like before doing this, I just reviewed something too. They're like, okay, it's the short acting and long acting beta agonist first, along with the inhaled corticosteroid. And then you're going to add more steroid. And then finally, you're going to go to like these orals, like the leukotriene ones. So I'm like, okay, that's where I was thinking. I wasn't thinking the inhaled corticosteroid first.
Wait,
And
say
after
it again.
reading
So
it,
So like, Okay, so asthma, right? So they're
Hmm.
gonna ask you this all the time. The rule of twos, right? They always
I
ask
don't know if
about
I
that.
remember rule of twos.
The
It's
rule of
ringing a
twos,
bell,
I
but
think it's like if you shoot, oh man, I want to say if
it's
you
like
wake
twice in
up,
a week or something. Let me look it up real quick.
yeah, something. It's like if you wake up in the middle of the night more than 2 times a month, then you need to start using an inhaled steroid.
Okay.
But you can look this
Yeah,
up.
it's
I'm pretty sure that's
daytime symptoms 2 times a week, night times 2 times a month. You'll need a
yeah. There we
reliever
go.
medication twice a week. So it's like,
Yeah,
okay.
so here, right, you are like, I mean, once you already see, some stuff, that you got to add on an inhaled steroid, which is fluticasone. So salmeterol is not a steroid. That's a long-acting
That's a
beta.
long acting. That's what I was thinking. I'm like, okay,
Yeah.
because there isn't a short acting available. That's why I picked, like, if they had albuterol, I would have said, okay. Um, because they're like, okay, on discharge, they're not, it seems like they're not giving the patient, I guess, switch from nebulized albuterol. That's what that means.
Yeah, the nebulized albuterol just means like it's in a droplet form. So patient's already on albuterol.
Oh, okay. So they're going to continue. Okay. With albuterol. Okay. Okay. Right. It's a pleural effusion question. Okay. And you can see the PE right here.
Okay.
I saw that. Um, they're not, I don't think they're really asking if it's exudative or transitive on this question in particular.
Well, let's go back to, like I said, let's break this down from chief complaint. Older person,
Okay.
hospital, 6 weeks of shortness of breath. So in your mind, you should
Okay.
be like, okay, that's like relatively chronic, 6 weeks is a long
Mm-hmm.
time, right?
Mm-hmm.
Then they start going, when you're 78, you probably have a lot of medical history, which is what they're giving you. You have colon cancer. And then this is the key here: congestive heart failure, pulmonary regurg, chronic obstruction, pulmonary disease. So it's COPD, congestive heart failure, and mitral regurg. So all those things can cause shortness of breath chronically,
Yes.
right? Um, Medications are X, Y, and Z, right? He's on supplemental O2 for a COPD,
Okay.
respiratory distress, right? All this stuff, right? Let's go through the rest. Let's see. I'm trying to get through it fast. His O2 is at 86, which for him,
Pretty
his
low.
baseline could be 88, right? Because he
Yeah.
has COPD.
Mm-hmm.
So,
Yeah,
that could,
88, 92. That's the goal usually.
yeah. So physical exam shows JVD, which makes sense if you have COPD, right? You're gonna have a little bit of right side heart
Mm-hmm.
failure, right? Hypertrophy of sternocleidomastoid muscles. Sure, I guess if you are using
Accessory
accessory
breathing,
muscles,
maybe.
but I mean, have I ever seen that? No, right? I don't feel on someone's muscle, like neck muscle, and go, all right, those are pretty beefy for your
Those are
COPD, right?
hypertrophic, right?
Yeah.
Right.
So, but sure, whatever. Physical exam discloses decreased breath sounds in the right lower lobe, dullness to percussion. So in your mind, you should be thinking maybe there's fluid there.
Okay.
Cardiac examination shows 3 out of 6 holocystolic murmur at the left sternal border, which can go with, mitral regurg, maybe, right? 2+ pitting edema. So, right side heart failure again. Thoracocentesis performed, it showed X, right? And in your mind, right, you should be thinking, all right, most likely this is just regular transitive pulmonary edema, right? Just on
Okay.
clinic. Okay. But let's say you wanted to figure out, is it truly right transitive? So if I think it's like less than a third or something, so you can do 85 divided by 230, which probably gives you less than a third, which is transitive. That means there's not much
Okay.
stuff in there. You get what I'm saying?
Yep.
So
I also
it's
think of the
transitive,
protein thing as 5, right? It's if it's
something
less
like
than 5 or something like that.
yeah, something
Or
like that.
no, sorry, less than 0.6. Oh, wait.
Yeah, I'm not 100%. I just use the lactate dehydrogenase because I remember
Oh,
that
okay.
formula. So you just take the lactate dehydrogenase of the pleural fusion, you divide it by the lactate dehydrogenase of the serum. So 85 divided by 230, and that should be less than, I think it says 0.5 is the ratio. So that's like,
Okay.
that's almost like 0.25. So it's very low. So you know that it's a transudate. So most likely just fluid from congestive heart failure. So how do you treat that?
Okay.
You give the patient Lasix, right?
So it's really just a heart failure question. That makes sense because before
Yeah,
it didn't
you
make
just
sense to me.
yeah,
Okay.
you just pee it out,
You're just
breathe
gonna
that.
diurese them. Gotcha.
Yep, that's it.
Okay. That's kind of it. Okay. Okay. I knew this was like an IBS question. Um, I really didn't know what to pick on this. I was like, I'm not sure. So let's see, because they tend to ask about IBS a lot, but they didn't show any. I guess they subtyped it too. Constipation, diarrhea, or mixed. Okay. I always
Yeah,
thought it
so
had to
this
be
is irritable
mixed.
bowel syndrome. So we don't actually know,
Yep.
what kind of goes with irritable bowel syndrome, but as long as you got that, you can kind of finagle your way to an answer, right? Because if you think about it,
Okay.
right, it's not a bacterial overgrowth or else she's going to be
Nope.
infected, right?
Yep.
Endomysial antibody formation, that's going to be a gluten intolerance, right?
Yep.
Medication adverse effect, you're thinking about opioid or something like that
Yeah, and she
causes.
doesn't really take medication. She takes ginger extract and
Yep.
multivitamin. I'm like, okay, that doesn't make any sense.
Stimulant laxative use, so you would have a lot of weight loss, diarrhea. She would have,
Hypokalemia, right?
yeah, she'd have anorexia probably, right? So the
Okay.
only
Yeah,
one
because
that makes
BMI is
sense.
like normal. BMI is
Yep.
normal. Okay.
Yep. So best one is going to
Okay.
be smooth muscle hypersensitivity due to irritable bowel syndrome.
Okay. Not a bad one. Um, let's see.
Okay, for talk me through the first sentence and tell me what you're thinking. Don't read on.
Okay.
Just
All right.
chief complaint.
All right. 80-year-old woman brought to ED family because of progressive loss of appetite, yelling of the skin for 2 months. Okay. So not super immediate. Um, yelling of skin. I'm thinking some sort of jaundice.
Yeah, good. That's it. Start with
Okay.
that, right? Maybe
Okay.
some kind of jaundice, meaning some kind of liver issue in your mind. That's what you
Mm-hmm.
should be thinking, right?
Mm-hmm.
Then she had a 40, 10-pound weight loss in this period, but says overall
Pretty
she's
significant. Okay. And
so
not
you got to be
eating.
thinking, if you have 10 pounds, older person, you got to be thinking cancer until proven
Cancer. Yep.
otherwise, right?
Yep.
Everything else looks okay, right? 80 over 60 is not, super good. But she's, icterus, right?
Mm-hmm.
She's jaundice, right? Her liver is huge, right? And then now,
Oh, what's the rule for this? Is there a rule for liver
yeah,
edge?
I just know
Okay.
that I don't know what the centimeter cutoff is, but 10 is a lot, right? 10 is
Okay.
like,
You can
like
feel it. Usually you can't feel it on patients. Okay.
yeah, like I mean, you can feel your liver, but it's usually you have to go under your rib to feel it. You know what I'm trying to
Yep.
say? So if
Yeah,
it's
see, I know that
10,
it's like not pain. It's kind of painful, so I don't do it on people usually.
yeah.
So
So if it's 10 centimeters below your rib, you're like, holy shit, that's a big liver. So
okay, okay,
um, but yeah, hemoglobin is a little bit low, direct bilirubin is more elevated than indirect, right?
mm-hmm.
Alk phos is super, super high, right? AST is a little bit high, right? So something with your liver, you're worried about cancer, right? So what are you going to do, right?
Oh, that's why
Cholecystectomy
you'd
is,
CT. It makes so much more sense
yeah,
now.
CT is going to be
Okay,
way better because you see what you see your liver, your gallbladder,
you
your
see
colon,
everything. Yeah, you're gonna
you see
see
everything.
everything.
Yeah, and then your cholecystography, right, is only for your it's only for your gallbladder, right, for the most part,
Okay,
and
I
your
was too
bowel ducts
stuck
and
in
things.
like, oh, this is obstructive gall, a biliary obstruction, but that's not really. It could be other things. We have to check for cancer, really, and
Yeah,
we can also see both things with the CT as opposed to just the gallbladder.
yeah, I'm gonna just get a
Okay,
better, wide view
gotcha.
lens of a CT. So it's a lot better. So you want to go broad scope before you go narrow. You get what I'm saying? Because let's say
Yes,
you do a cholecystography and then it comes back negative. Are you gonna stop? You get what I'm trying to say? Right?
gotcha.
If anything, you want to go more sensitive and then go specific. So let's say you do a CT scan of the abdomen, you're like, oh, I think there might be there might be a gallstone cancer or I mean a gallbladder cancer. Okay, now let me do something more specific for the gallbladder. You get what I'm saying?
Okay, okay. That makes sense. I guess it's kind of same with this too. Same idea.
What is this one? Let's see. 2 episodes of vomiting over the past 16 hours. Epigastric radiates to the back. Fluid, 2 days. Vital signs normal. 101. So he's infected. It's acute.
Mm-hmm.
Abdominal pain, but liver is okay. Spleen is okay. Bowel is a hypoactive. Stool is negative. And
Mm-hmm.
then NG tube, green tinge fluid, meaning he has some kind of bowel obstruction, right?
Okay.
Obviously, leukocyte count super high. He's infected, right? Amylase is
Mm-hmm.
pretty high. So in your mind, you're like, okay, he
I'm
has some
thinking
kind of obstruction,
pancreas. Mm-hmm.
right, of some sort,
Mm-hmm.
right? And then CT abdomen is going to show you something, right? Like and he's a history of alcoholism too, right? So that's going
Yes.
to increase your risk of acute pancreatitis. So best answer here, definitely for sure B. So F is going to be only good if you're thinking of a common bile duct stone and you want a diagnosis
Okay.
and treatment, but you don't know you don't know what's causing what, so you got to get a CT scan first.
Okay. Okay. So again, too specific
Too specific.
and also like a little off. So it's like, okay, that's why the CT is going to make more sense. All right. This one I thought that partners, because I know trichomonas could or could not be STI. So I'm like, okay, I thought there's like a rule where the partner doesn't take the drug. Because it's like, okay, I knew the treatment for it. And I thought about this one. I'm like, oh yeah, you wouldn't. It's like a 24-year-old man. His fiance had a urinalysis 2 days ago, showed trichomonas. They're sexually active. He hasn't had any symptoms, doesn't take anything. And I'm like, okay, I don't think in this case you would give it to the partner because it might not be STI, but that's not what they're saying. They're like, all right.
Yeah,
Um,
you want to give it to, you usually treat
both.
person and partner for
Okay.
most STIs, I would say.
Okay. Let's see. All right. So if we're going big picture here, 72-year-old woman, multiple myeloma, brought to the physician 1 day history, so pretty acute here, shortness of breath and fatigue. Respiration's okay, blood pressure okay, no orthostatic changes. Cardiac exam shows decreased heart sounds. Well, she does have multiple myeloma. Um, let's see. Urea nitrogen's high, creatinine's really high. Something's going on with the kidneys. We have 3+ protein. We have low fractional excretion of, oh, it's high. I'm sorry, more than 1%. And then a low post void residual volume. So I wouldn't really consider that. 24-hour collection shows 3.5 grams of protein. It's a lot. Creatinine clearance of 10. So it's, is it going even higher? Oh, no, that's milliliters. I don't know if I know what renal parenchymal disease is. I guess the parenchyma of the. Hmm.
So this one's kind of interesting. Let's talk about this. So multiple myeloma, that's the key here, right? You always want to start
Mhm.
with that. Okay, multiple
Amyloidosis, I'm
myeloma.
thinking with the.
So remember with multiple myeloma, right? You create a bunch of IgG that kind of clogs your tubes and cause kidney damage. That's one of the
Okay.
key things with multiple myeloma is where you have an overproduction of antibodies by malignant plasma cells, right?
Okay.
Because the plasma cells will create your IgG. And so what will happen is those IgG proteins will then clog your kidneys and practically damage them because your kidneys are trying to filter out your blood, but your blood is thickened by all this protein, and that protein kills your kidneys. And key thing of figuring out that is because one, patient is peeing out a bunch of protein, 3+ proteins. Two, creatinine and BUN is super elevated, meaning the kidneys aren't filtering out very good. You know
Mm-hmm.
what I'm saying? And so
Yes.
the best answer here is to connect multiple myeloma with kidney disease. So it can't be bladder
Okay.
obstruction, it can't be heart failure. Interstitial nephritis only happens. That's acute interstitial nephritis, right? That happens
Okay.
with if you use certain drugs and you pee out white blood cells because it had your
Oh, that's
kidneys
like
have like
the reactive one. Okay. So it's
yeah,
like,
like an
okay.
allergic reaction of your kidneys.
Okay.
All right. And
Okay.
then renal vascular disease is like, let's
I'm
say,
thinking like hypertension, right? Or something
yeah,
like that, where the arteries stay
hypertension
close.
or, some kind of clot or something, right? So the best answer here is going to be that renal parenchymal disease, which just means
Makes
like
sense.
damage to your kidney. That's practically what it
Okay.
is. Yeah.
That makes sense after talking about it. Okay, so this is FSGS, which is also with HIV. I thought they were going with the cryoglobulin. Sometimes they ask about like hepatitis with the cryoglobulin. Um, hmm, Sort of a busy question.
Very busy question.
Hmm.
So abnormal. Let's look at abnormal here. So positive, right? Antigen of Hep B.
Hmm.
Um, peeing
Or no,
out a bunch
positive
of,
antibody, right? So it
yeah,
has like
antibody.
so
So, not
past history.
actively, but did have Hep B in the
Hmm.
past.
Hmm.
Peeing out a bunch of protein. Um, red blood cells, not too much. Leukoesterase, so he might have a UTI also.
UTI. Yep. Thinking about that.
Creatinine's 3, so his kidneys are not great for a 27-year-old.
Hmm.
AST is elevated, right? So some liver damage there too. So now the
Yep.
question is, okay, what's most likely cause of kidney damage, some liver damage, and also peeing out protein? So can't be cholesterol, can't be cryoglobulin, right? Because I think cryoglobulin you need your C3, maybe. I can't
It
remember
Yeah,
what
it should have been more elevated.
yeah.
I was just thinking they because of that connection with the hepatitis, but it's not an active infection. If it was active, that would make more sense, but it's not.
Yeah, I'm trying to remember what else with cryoglobulin. I think you get some skin issues, dermatologic issues too with cryoglobulin issues, but diabetes is not going to really, there's no really risk factors for and it doesn't tie in with the Hep B. And HIV, right? Once again, is not really kind of in this picture. I think just best is heroin due to IV drug use causing Hep B.
Yeah.
That's going to be
And
kind of
then I
my
know that
best.
that causes, yeah, FSGS. If I think of, I'm just like, yeah, I remember that from renal. It's just like, yeah, FSGS, you should be thinking drug use. Um,
Yeah.
and it's in that nephrotic, more nephrotic than blood. So, but it is busy. So this
Yes.
one's easy to get lost in the details. And again, that's what happened where I got lost in these very
Yeah.
specific things and I attached to them as opposed to being like, all right, well, let's look at the big picture. It's
Yeah.
definitely nephrotic. You have the swelling.
Yeah.
That's the most
Just big
important thing
picture.
here. And
Yeah.
it's like, okay, what's unique about this patient is probably the HIV for sure. And then, but his HIV was negative, like testing for HIV was negative. So then the heroin use. So that's probably the biggest thing. It's the injection drug use. Okay. Let's see. See, this one I thought was the herpetic Whitlow, and it wasn't that.
Migrating wrist, pustules, tender pustules, right knee. Oh, but remember this patient it seems like this patient already also has, it's all over the body for one, and for two, might have some arthritis kind of ordeals too.
Okay.
So in your
So,
mind, you got to be thinking, okay, that's weird. How does this stuff get all over the body? So, acyclovir is good, like herpetic Whitlow, but that's not going to migrate. So that can't be it. It usually stays around a certain
oh,
spot.
okay.
And then I'm trying to think. So you're trying to connect the antibiotic with the possible disease that it's trying to treat, right? So
Hmm.
sulfa, I can't really think of too many sulfa things that can cause skin
Well, I'm
like that.
thinking like TMP SMX, right, for that. And
Yep,
I'm like,
yep,
I don't,
yep.
that's pretty like hard hitting antibiotic. And it's like, this doesn't seem,
Yeah.
um,
And tetracyclines, your cyclines are going to be for like, for um
Lyme, I think of like with
yeah, insect
tetracycline.
stuff, right? So
Hmm.
insect like
Hmm.
outside, tick-borne and things like that. But this is a very odd thing, right? For ticks because animals, I mean, they can like I guess like Tarantula and things like that from rabbits and stuff, but they usually give you some sort of background of
Yeah, they
animals.
give you more hints for that usually.
Yeah, so kind of interesting. But yeah, ceftriaxone here for gonorrhea, so which can give you all sorts of skin issues
Which
and
makes
whatnot.
sense. And it makes sense now that you're like, yeah, this is all over and it has the arthritis component too. So I'm like, okay. So in some ways, I focus too much on that picture and not like, okay, well, again, what's the bigger picture, not just that small little lesion.
All right, let's talk a little bit.